everyone, welcome back to the Endo Education Podcast. I'm Nicole Notar, founder of Endo Excision for All, and today's episode is an important one. We're diving into what truly comprehensive patient-centered endometriosis care should look like and where the future of diagnostics and treatment are heading. I'm joined by Dr. Erica Stockwell, who brings incredible insight into both the surgical and multidisciplinary aspects of endometriosis care. So if you or someone you love is navigating endometriosis, this episode is for you. Dr. Stockwell, thank you so much for being here.
Thank you for having me on, Nicole.
Of course, if you want to just introduce yourself a little bit and then we'll get started.
Yeah, of course. My name's Dr. Erica Stockwell. I am an advanced gynecologic surgeon, a fellowship-trained surgeon at Celebration Hospital with Abbott Health in Florida. And I've been practicing for, what now? Over 10 years. Geez, that makes me feel old. Over 10 years, and have a huge focus with regards to endometriosis, the treatment not only surgically, but also providing that comprehensive care like you mentioned. So I'm excited to talk about that today.
Thank you. So we'll kick it off with that. If you can just define what comprehensive endometriosis centers actually look like.
Yeah, so endometriosis, I think the mainstay treatment for endometriosis of the past has been focusing on hormonal suppression, surgery when needed, and really hasn't been focusing on the entire package or the entire focus of endometriosis. We now know endometriosis is a lot more than just bad periods. And I think that, I think what you're doing and with this podcast is kind of bringing to light a lot more information out there, that we're actually seeing a lot more focus on endometriosis, a lot more awareness around endometriosis, not only from the OBGYN community, but also from other specialties as well. ER, primary care, and so now I think is the perfect opportunity to really help to build centers focusing around the entire comprehensive care for endometriosis. We know endometriosis is a whole body disease. It's not just a GYN disease. It affects the whole body. It affects your, affects you neurologically. It impacts lymphatics. It impacts so much chronic inflammation that can impact other organs and other organ function, your musculoskeletal. And so really the best care for a patient living with endometriosis is not going to be isolated care to look at just specifically what is the GYN effect, but really kind of targeting these different impacts to these patients from these different multi-specialty approach. I tell my patients all the time that if we have this grand scheme of effects that endometriosis causes in the body, and we're really just focusing on the lesions themselves, or we're focusing on one aspect, the periods or the pain or the fertility, then we're really missing the whole picture. And really that's going to lead to frustration because it's going to be incomplete treatment for the patient. And also, I see so many times too, with even my colleagues, other surgeons, that they'll excise, they'll treat, and then it's like, okay, yeah, good luck, on to the next. Yeah, that's not the appropriate treatment either, because we know that surgery is not a cure. Yeah, as a surgeon, I wish I could tell patients, yeah, I'm going to cure you, I'm going to solve the disease. But unfortunately, that's not going to happen. And so if we don't provide a game plan for that patient to follow in the care and the appropriate treatment following surgery, they're going to have incomplete treatment. It's going to lead to basically regression back into their prior state of pain and potentially worsening pain over time. And so we really need to look at this comprehensive approach. So, I mentioned I work with it for Abbott Health. Abbott Health for Women actually has a big focus on endometriosis. We're actually building an endometriosis center right here at Celebration, Florida. Yeah, it's been a plan in the works for some time here. I'm heading it along with Dr. Eileen Caceres, who's also an endo expert here in Celebration. And we're trying to build a center that brings all these multi-specialty providers under one roof and be able to provide that kind of standard track, not standardized track, but like a roadmap. That's the word I'm looking for. A roadmap for patients who are having symptoms of the disease or diagnosed with the disease to have really a track for them. And so, we here at Celebration, we have all the different specialties and we were doing great care for a long time. But I think it has been hard for patients to really identify and find, who are those ones that are focusing on endo. Not all GYN surgeons focus on endo. Not all OBGYNs have an expertise in endo, and you're not going to get the same care if you don't go to someone who really understands this disease and the chronicity and the treatment options for it. Same thing with colorectal GI. I mean, it's not all GIs and colorectal surgeons focus on the same thing. We all have our kind of different areas of specialty and our different areas of focus and expertise. And so it's really hard for patients to navigate that, even for us as providers, unless I'm kind of forming my team around me and really knowing who I trust and who I'm going to refer to. We as providers, or I see it for, our primary care or other OBGYN providers, if they have patients that are having symptoms, urologic symptoms, if they have patients that need more comprehensive care because of the fact that endometriosis impacts all of these other systems, it's really hard to navigate that and figure out who do I send to, who's going to provide that care for the patient. And so anyway, so that's what we're trying to do and trying to build here. We have a great team of providers who really do focus on endometriosis within GI, within colorectal. We have a general surgeon here who really focuses a lot on endometriosis. We have a cardiothoracic surgeon who really specializes in catamenial. And so we see a lot of that here. We have a great pelvic floor physical therapy team. I refer every single patient to them, and they're amazing. They really help a lot of my patients out. We have pain management, and that's really hard too, finding pain management that focuses on chronic pelvic pain, because most pain management, it's ortho pain, back pain. And so, we're trying to kind of build this into one center that helps to navigate patients through this process. On top, the cherry on top is really a patient coordinator, patient navigator who's going to be able to create this track for these patients that are coming in with this disease. And unfortunately, it's a lifelong disease. And so this is it's establishing chronic care for these patients to be able to give them good quality of life.
That's incredible because, like you said, it's so difficult to find a doctor that you, one, can trust is actually knowledgeable on endo. And two, the multidisciplinary aspect. What would be your advice to a patient who's with their traditional gyne, who's telling them like, "Oh, you don't need to go get excision. Yeah, I do a minor procedure here for an hour. We know it's ablation." Like, what's your advice to that patient who's built a rapport with their traditional gyne? Maybe they're 32 and they've been with that gyne since they were 14. So they trust them, they have a rapport, and but then they see everything online and from the endo community about going to excision. They're kind of tossed in that like, do I believe this person that I've been trusting for over a decade, or do I believe the education I'm finding myself online?
Yeah, no, that's a good point, and we see that a lot too, and it's unique in GYN, right? Because you have that, you build this rapport, you see this physician through, it's basically, it's primary care for women in the GYN regard, so it is kind of, and especially if, these are the physicians who are delivering, walk you through pregnancy, delivering your babies, or, maybe you've seen them since you first started your period, and so it is kind of hard to navigate that, especially if they're telling you, oh, well, I could do this, I can ablate, I could take a look. And it's unique to GYN. I mean, you don't really have that in like urology or, that it's very unique to GYN, this predicament here. But as far as navigating that, I would say, there are surgeons out there, there are endo experts out there who really know and understand this very complex disease. It's not only a complex medical disease, it's a very complex surgery disease. And, to treat it to optimally treat it surgically, you really need advanced training in endosurgery. And so there's kind of three layers to this. We have our generalist OBGYN pool, who really don't get a lot of endo training in residency. I mean, I went through residency, I went through training. We did some endo. We basically, saw it, diagnosed it, maybe tried to treat as much as we could. We did a lot of ablation. That's what we were taught. And then I went on and I did a fellowship training. And even fellowship trained surgeons are not all alike either, because in fellowship you might have different areas of focus. There are certain fellowships that focus a lot more on fibroids and treatment of fibroids. There are fellowship programs that treat a lot more urogynecologic, pelvic organ prolapse, these type of things. And so to find someone that really knows chronic pelvic pain and treatment of endometriosis and surgical expertise to treat endometriosis is hard. So I would say I would just, encourage patients to and empower patients to really start to ask those questions. Say, okay, well, how many endometriosis surgeries do you do in a year? If that surgeon's not doing hundreds of endometriosis surgeries in a year, I would have pause to go to someone who does maybe one or two a month or so. And then ask them, how do you treat the endometriosis at the time of surgery? Are you ablating? Are you excising? Are you slicing adhesions? Are you deep delving into those deep areas within the pelvis? Do you examine the diaphragm? Do you look in the bladder? I think that it's important for patients to feel empowered to be able to ask these questions in order to find the right care for them. I think that it's also important that you ask your surgeon, do you have a multi-specialty team? Do you work with other surgeons who can help you if we do find endo in the ureter that needs to be resected? Do you have someone that you work with, or do you yourself do bowel resection in case, we come to the point where we need bowel resection? Do you treat diaphragmatic endo? So, even within those who are, kind of toting themselves as endo experts and endosurgeons, there's still a lot of variability. So I would say my biggest takeaway is I would just empower patients to ask those questions and make sure that they are feeling comfortable. We see a lot of patients that travel here from out of state. We see them through a Zoom call like this or telehealth beforehand, and we make sure that patients are feeling comfortable and understand and know what that care is going to look like before coming in.
Does it something when it comes to the actual surgery itself that we get lots of questions from patients on when they're looking for a vetted surgeon is robotic surgery versus haptic. What role does robotic assisted surgery play in endometriosis treatment, and how does it compare to traditional laparoscopy?
Yeah, I'm a big proponent of robotics for endometriosis. And I do, I have done the whole gamut of different approaches for surgery, including vaginal laparoscopy and robotics. But I feel like, especially for endometriosis, robotics has such a benefit. You have improved 3D visualization. You're able to have magnified visualization. So I'm able to actually even digitally zoom into areas, the deep infiltrating areas. I feel like I can see lesions so much better in little areas that I traditionally probably was missing, unfortunately, with conventional laparoscopy. And so I've converted my practice to basically 100% robotics because I feel like there's such a benefit of it. You have wristed articulation, which means when your instrument is in there, you're able to move it just like you would your wrist versus conventional laparoscopy or kind of working with, chopsticks. What else? We have advanced imaging. We have things like Firefly technology, which is specific imaging to potentially help identify lesions or areas of hypervascularity. With the newer robot, the Intuitive DD5 robot has force feedback. So you can actually feel and see how much force you are applying to tissue, which has been shown to help decrease tissue damage. And as we know that a lot of pain and inflammation comes from tissue damage, if I can operate in a more gentle way, and if the robot is telling me how much force I'm applying to the tissue, then that patient's going to have a better outcome and they're going to have less pain in their recovery. So for me, especially, endo, I've gone 100% robotics because I feel like it just has so many benefits. And I feel like there's just more and more coming with that. There's, coming down the line, we have potential for image integration and image overlay. So being able to take that patient's MRI, have it up on the screen, and even overlay it with what you see live view. And when you're operating on the patient, can help identify deep infiltrating lesions that might be under the surface. So there's a lot of technology within the robots that can be extremely helpful for me as a surgeon with endometriosis. And one more thing too is the ergonomics. Endo cases sometimes can be very long cases, many, many hours, and we all fatigue. And if I'm standing at the bedside and I'm operating like this with my laparoscopic instruments, it's more fatiguing. If I'm able to sit comfortably at the robot and do this with my arms instead of doing this, I'm not going to fatigue as fast. And for me, I'm going to be able to bring my A game to that entire case and do more cases in a day, do more cases per week. So I think there's so many benefits to the robot.
Like your point. That's really interesting to learn about that MRI overlay.
Yeah, yeah, coming
That's
down the
really
pipeline.
that's really cool. So there's a lot of exciting things coming down the pipeline, it seems.
Yeah.
I think there's we touched on it before with the emphasizing the whole body care of endometriosis and treatment beyond surgery. Typically, what does care look like after excision surgery? Because we also get a lot of questions from patients who are like, I had surgery and at my follow-up, and my surgeon's just like, we removed the endo, you're good. And they're like, well, I still have hip pain or leg pain or back pain, or like, I'm scared of the pain coming back. What do I do now? And a lot of them just like abandons after that. So what should care look like after excision?
Yeah, so I talk to my patients about, basically we have kind of three different categories of treatment for endometriosis. We have this very broad category of lifestyle modifications, and this includes things like nutrition and exercise, and I would include the pelvic floor physical therapy in there, and different things and techniques that they can do from home, sleep hygiene, things like that. And then we have this broad category of medical treatment options, and this category is expanding. We have treatment options to potentially help to target endo. We also have a lot of different type of treatment options with regards to pain management, anti-inflammatory. And so there's this category. And then we have, of course, the surgical category. And the surgical, I think, is actually the most straightforward. It's excision surgery. I mean, that's the mainstay for surgery. And so and I tell my patients, we kind of, because it is a chronic disease, it requires and deserves chronic management. It also deserves the multidisciplinary approach to it. It's not only a hormone driven or surgery driven disease. It's a multi-system inflammatory disease. And so we get that patient into a track where they're following up with, nutrition and dietary changes. They're following up with pain management. They're following up with pelvic floor physical therapy. I try to get my patients to see pelvic floor physical therapy very shortly after surgery and start working with them. There are things that they can benefit from in the post-op period, such as lymphatics and gentle introduction into different exercises and stretches and things like that can actually help in the recovery period, as well as certain anti-inflammatories to add to the diet, or certain supplements that they could potentially add to the diet. And so I would say surgery is part of this, part of the treatment pathway, but it's not the end all be all. And in fact, it might be the very start, the very start of it to coming up with the course of action or the next step in the treatment of these patients. So I also, but for my patients, I see them back very frequently initially. I'll see them at 1 to 2 weeks after surgery. I usually will see them again anywhere between 6 to 12 weeks following that. And then I will continue to see them frequently until I really know that they are, they're starting to feel better. They're having improved quality of life, feel more like themselves again. And then we'll push it out to potentially every 6 months. I never wait longer than 6 months before touching base with my patients with endometriosis. And we talk about, when we look at the other thing I think is really important for patients is with any type of chronic pelvic pain, of course, in my practice, endo being a big one of that. But I think that it's important to kind of reframe how we look at success too. I try to reframe the verbiage on not necessarily focusing on the pain and how much pain you're in and what is your 0 to 10 pain scale. I try to reframe the focus on looking at the goals with quality of life. I have so many patients that tell me I'm in so much pain and I'm exhausted and I feel like I'm a bad mom because I can't do the things with my kids that I want to do, or patients that tell me, I'm in so much pain, I'm calling out of work, and when I'm at work, I'm barely at work, and I just feel like I'm just making it by. And so we're looking, or our patients that tell me, I used to really like to, ride my bike or whatever it is. I used to really like to travel, and I feel like I can't do it because I'm in so much pain, or I'm having to, reschedule my life around my pain or my periods. And so when we reframe it to look at those quality of life metrics instead of focusing on the pain, and we look over time, when patients come back, I ask them, I say, how are we doing with your work? Are you calling out of work as often, or how are you doing with your kids? Are you able to engage with them more? Are you able to do these things that you wanted to do? How does that look? And for me, that's a much more meaningful, to establish that and see really how are they doing. Because for me, it's the improvement in the quality of life is the main goal, right? Of course, we want to eradicate pain or improve pain or manage pain, but really the ultimate goal is the improved quality of life.
Yeah, that's how this disease affects our life is a huge metric, and it's a lot of times just ignored. And that plays into the whole medical gaslighting. I can't tell you how many appointments before I found the right doctor and got diagnosed was like, I'm calling out of school, or I'm not going to school, and then eventually I'm calling out of work, and like, well, yeah, it's supposed to be if you have endo, it is really uncomfortable, but just take here's some painkillers, and like, no, it's not uncomfortable, it's debilitating. Like well, you're sitting in this office here today, so why can't you go to school? Well, it's not 24/7. It's when I get my period or the week leading up to it, or ovulation. Like for me, it was very period related. Um, yeah, just like not being listened to about that. It's like, no, that's data. That is screaming to you that
Right.
this disease is debilitating. And that's like I always tell patients that are like going into their consults or talking to their providers and trying to like get a referral, like use the word debilitating
Yes.
and emphasize that. Say you're exactly what you just said. Say you're missing work. Say you're missing school. Like the doctor needs to know that. That's how they can measure or really try to understand the level of pain that you're having. The
Yeah.
what like the scale of 1 to 10 doesn't really emphasize debilitating or not.
I hate that scale.
Yeah.
Yeah.
So it's good just to like reemphasize with everything you just said that like surgery can be life changing, but it's not the whole story. And that's something that I feel like our endo community is really starting to understand more deeply. I'm personally learning to understand more deeply. But when it comes to the going back to the conversation before with the OB-GYN expertise, just the difference in OB-GYN expertise again. So why is there such, because we talked about the difference, but why is there such a wide range of expertise in diagnosing and treating endometriosis? Is it training gaps that currently exist?
Yeah, I think it's multifactorial. So there's not a lot of focus on endometriosis in current training in medical school and in residency training. And part of it, and it's not the OBGYN's fault. I mean, part of it is there's just so much to learn. I mean, for basically for you to have only 4 years of residency, so you have 4 years of medical school where you're trying to cram in as much knowledge as you can about everything, about from a cellular level, microbiology level, like everything pharmacological. It's a lot to learn in your 4 years that you have to learn that, and then you have 4 years of residency where you're really focusing on women's health. And even within women's health, for us to come out of 4 years of residency training and say, okay, you're a woman, I'm set, I could treat you and treat all of you and all the things that come with it, is really, it's a big ask. It's a big ask for OBGYNs. And so I think that part of it is this dearth of training, unfortunately. There's only so much you can fit in that 4 years of training. There's a lot that OBGYNs have to learn about obstetrics. There's a lot that they have to learn about GYN. There's a lot they have to learn about surgery. And there's a whole lot more than there ever used to be in all this, but we haven't seen the expansion of the training program go from 4 years. It's been 4 years and been 4 years forever. But we have now a lot more types of surgery. We have robotics, we have laparoscopy that has been introduced. We have different technologies. We have things now like radio frequency ablation. We have many more different type of medications and drugs out there that can treat these, and a lot more complications that we're seeing in the obstetrical world, where we're seeing a lot more complicated, medically complex patients with complex medical histories that are getting pregnant. We have different, ability to get pregnant, where patients in the past have had issues getting pregnant because of fertility. So I think it's just so much and becoming more and more and more complex. So there's been this discussion too of, do we separate the O from the G, the obstetrics and the gynecology, and do
I
we
was going to ask you about that. That was a follow-up question.
like, do we start to track? And I think that makes a lot of sense. I went into OBGYN because I thought I was going to do it all, and I wanted to do it all. I wanted to deliver babies, and I wanted to be an expert surgeon, and I wanted to be able to do it all. And I think that unfortunately it's just not possible. As I found through my training, I really had to kind of pick and choose and focus on one. And I really wanted to be a good surgeon, and I really wanted to provide this type of care for the patients, because I saw that there was a lack in really good surgeons in GYN, and again, not the OBGYN's fault. They just have so much time to learn everything. And so I wanted to focus my training and get some extra expertise. So I think that, part of it is the lack of training, but also just the lack of time frame to train. It's because it's the old adage of, I could do it all. As an OBGYN, I could do it all and treat it all. And I think that needs to change. But also I think the other component of it with endometriosis is this not only a GYN disease. I mean, it's a very complex whole system, inflammatory, multi-organ disease. And we can't just put it on the OBGYNs. Like, we need training cross specialty. We need our urologists to learn this. We need our GI specialists to learn this. We needed to focus more on this multi-specialty approach to endometriosis. And I think that has also been a huge detriment to really being able to establish good care for endometriosis in the past. And I think that there's a lot that needs to change with it. I think part of it is, yes, more of a focus early on in medical school for those to start learning and be exposed to this in training, and have different tracks that you can choose. And then really across the board, our primary cares need to know about this. Our ER physicians need to know about this, and really just getting the knowledge out there.
That just thinking about like the appointments I've had with other specialists and how many are like, oh, endometriosis, well, that doesn't matter here. You should be bringing that up with your guy. And I'm like, No, and I've even dealt with that with my mom, taking her to doctors now, and she's been postmenopausal, but was really struggling. And like all her now knowing like how many of the issues she's having now, like can lead back to endo, and she's surgically diagnosed with endo. Um, but just talking to all these different specialties about it, and then like, oh well, you talk about the gyne about it, but even that, like you're postmenopausal, so the endo's gone away.
Yeah.
I'm like, so you think like you grow endo in your body and then all of a sudden you hit menopause and all the lesions just melt away. They just melt like they're gone. That's I feel like we would have a cure by now if that's how that's what was working. So yeah, just hitting the nail on the head with everything you said. It really resonates with me, and I feel like it resonates with a lot of people that are listening. But you talked about too, like the emerging diagnostics and just everything that's coming down the pipeline. When we talk about early detection, why is endometriosis still so difficult to diagnose early?
Yeah, well, it's difficult because it's really hard to pick up. It's hard to pick up on imaging. It's hard to pick up through blood work. I mean, and I think also goes back to kind of this dearth of knowledge too, where if you don't have someone that can identify some of the early symptoms of this, if people get gaslighted, like you mentioned, oh, it's just bad periods, honey, you gotta push through it, or this is how it always is. Like, welcome to being a woman. I've heard it all, and I think that the gaslighting, the lack of knowledge, and the lack of really great diagnostic tests have led to this. Unfortunately, several year delay in many patients getting the treatment that they deserve, and so I'm really excited that there has been a shift, and it's really, I mean, it's happening now. There's a shift in the focus of treatment for endo. It's always been hormonal suppression and surgery, and that was basically it. You're on birth control, you have surgery, go back on birth control, and that's been the focus of treatment for endometriosis. Now we see, thank goodness, some things that are coming down the pipeline that are focusing more on the endo itself, endometriosis, and targeting it more like a cancer, and specifically targeting the lesions of endo, not just suppressing it, not just trying to, throw hormone at it, or, you were really focusing on the endo growth itself. And some of these medications that are currently actually just entering, just last month, one of these medications is now opened up to human clinical trials. That is a specialized peptide focusing on the endometriosis lesions itself, and focusing on lesions that I have angiogenesis, and so focusing on it more like a cancer type treatment, I think is going to change the scope of treatment for endometriosis, not just trying to suppress it. We need new non-hormonal alternatives and other treatment options. As far as diagnostics, there's a lot that is being done looking at ways that we can help pick up endometriosis earlier. In fact, I think it was just last week or a couple of weeks ago, there's some article that came out on a new type of imaging that I'm super excited to learn more about, that utilizes CT, but specifically molecular radio tracers that bind to specific areas that have increased inflammation. So this may be helpful in diagnosing that superficial peritoneal endometriosis disease that just doesn't show up on imaging. And then we have diagnostic tests such as serum testing through blood work. There's tests that are looking at your menstrual blood or vaginal mucus, and endometrial biopsies. So all of these look for different inflammatory markers that we know are very highly suggestive of an endometriosis process. So all of these are still very much, early in with regards to, they're not gold standard yet. I'm hopeful that soon they will be, but they still have to be studied. They still have to be proven. They're still not 100%. I mean, there's still, but if they can help to find that diagnosis and find it earlier, and then get patients on the right treatment path, and if we can halt the disease or at least start treating the disease early on, we really can change the scope of someone's life. I mean, we can prevent it from progressing to the advanced stages where it can cause scar tissue and infertility and central nervous system, sensitization. And we can really change the scope of someone's life if we're able to diagnose and treat this early.
That's I'm happy that was going to be my follow-up too, is like how does early diagnostics change outcomes? Because we get so many patients who are like, I want to go down the road of finding out if I have this, but also like, what's the point? Because I don't want to do surgery anyway. That's like a last resort for me. So should I just like treat myself as if I have it and, just go by whatever my guide says and, or whatever they see online in terms of like lifestyle changes and things like that. So we're always trying to emphasize like early that you need to know if you have this disease. And ultimately, like you said, like the gold standard right now is excision surgery. So, even if you're like, oh, I don't want to jump into surgery right now, you'll still need to know if you have this, or, I guess you technically don't know until you have surgery, but just talk to somebody who's a specialist who can say, yeah, you probably have it. Like, let's be careful of XYZ. Let's keep this in mind, instead of just living your life not knowing.
Yeah, it's still, I mean, the gold standard still right now is laparoscopy for diagnosis, but I think we'll see a change. I think we're going to come up with some better tests that are able to give us more of that yes or no answer that we're looking for, and potentially help to, even actually help to actually prevent some of the surgeries that we're doing for endometriosis. If we could target it early and get a hold of it early, then potentially it'll help to decrease the amount of surgery that our patients are needing.
Yeah. We all know one of the biggest challenges in endo care is the delayed diagnosis. So it's good to know that all this promising work is being done.
Yeah.
Before we finish up, I always like to ask providers what their number one piece of advice is for a person with endometriosis or suspected endometriosis, just dealing with this whole entire journey.
Yeah, I mean, I would say ask questions. I think that because there's so much that we're still learning about endo, and because there's not this overall expertise in endo, I think ask questions, and be ready to ask those questions. If you're hearing, oh, well, you just need to be on birth control or take some ibuprofen, or it's just bad periods, or yeah, endo's painful, it's just how it is, ask those questions and get into the community and become involved and do the things like you're doing, Nicole. And I mean, reach out, ask what other patients have gone through, ask them, what has worked for them, ask them what hasn't worked for them, ask them their course. And I think that just putting voice behind it, I think is the biggest thing that's going to help to change it. And I know not everybody feels comfortable with that, putting their voice out there or doing these things and being online, but but I empower patients to do it for themselves, and not necessarily to be on social media and all that, but ask those questions for yourself. Ask your provider, and make sure that you're getting adequate treatment, and make sure that you are following your symptoms and you're looking at it from that quality of life metric, and that you reach out if you're not getting adequate treatment. Reach out and find someone who's going to listen to you, make sure you feel heard, and make sure that that person's not just going to operate and send you on your way either. Make sure that you get into someone that's going to really put you on a good treatment path for the course of your life.
Dr. Stockwell, thank you so much for sharing your expertise and for the work that you're doing to advance endo care. For those in the Celebration, Florida area, where can patients find you?
They can find us through Advent Health for Women. If they just Google Advent Health for Women, you'll find us on the website, and I can send you the link for that. But they'll find me there. I'm in both Celebration. I'm also in Lake Nona, outside of Orlando.
Thank you to everyone listening. You deserve informed, compassionate, and specialized care. That's our mission at Endo Excision for All, is to make that level of care accessible for everyone, not just those who can afford it. So if this episode resonated with you, please share it with someone who might need it. And as always, you can learn more about our work, resources, and advocacy efforts by visiting us online at endoexcisionforall.org. Thank you for being part of this community, and we'll see you next time.
Thank you.